1 in 5 American adults experiences a mental health condition in any given year. Less than half receive treatment. Emergency departments across the country are boarding psychiatric patients for days because inpatient psychiatric capacity does not exist to receive them. Behavioral health integration is not a program add on, it is a core operational necessity for health systems in 2026. Four things administrators need to understand to lead this work effectively. First, the collaborative care model is the most evidence supported framework for integrating behavioral health into primary care. It places a behavioral health care manager and a consulting psychiatrist in the primary care workflow, supported by a registry that tracks patient outcomes over time. It has over 80 randomized controlled trials behind it. The barrier to implementation is not evidence. It is reimbursement structure and workflow redesign, both of which are administrative leadership problems. Second, reimbursement for behavioral health services has improved but remains complex. Behavioral health parity law requires that mental health and substance use benefits be covered equivalently to medical benefits. Enforcement has strengthened. Administrators need to understand parity compliance requirements and ensure their contracting and utilization management practices do not create de facto barriers to behavioral health access. Third, the behavioral health workforce shortage is severe and will not resolve quickly. Psychiatrists, psychologists, and licensed clinical social workers are in short supply in most markets. Telehealth delivered behavioral health has demonstrated equivalent outcomes to in person care for most conditions and dramatically expands geographic reach. Incorporating telebehavioral health into your care model is not a future consideration, it is a current operational requirement. Fourth, substance use disorder treatment. Integration follows the same operational logic as mental health integration. Medication assisted treatment for opioid use disorder, primarily buprenorphine, can be delivered in primary care settings by trained providers. Health systems that have not yet built MAT capacity into primary care are leaving a high need, high cost patient population without evidence based treatment. Behavioral health integration requires capital, workflow redesign, and sustained leadership attention. It also reduces ED utilization, improves chronic disease outcomes, and positions your organization for value based contract performance.